It's my pleasure to address you on this question of how we could improve childhood TB diagnosis through treatment decision algorithms, combining, as was said, clinical, radiological, and laboratory data. And again, thanks to the organizer, Alfredo, Titus, for inviting me to this aperitivo webinar. You're probably all familiar with the WHO numbers and estimates of childhood TB burden and the diagnostic gaps. And if we look with a kind of more broader view on childhood TB burden, you probably know that 1 of 10 TB cases overall in the world is a child. So 1.25 million out of 10.6, or one in 10, that roughly half of these children with TB are very young, below the age of 5 years, that below 50% of children, less than half, are diagnosed with TB, and leaving 50% undiagnosed, that 1 in 4 or 1 in 5, 20 to 25% of children with TB die, and mostly the quasi majority of them because they are not on treatment, because not diagnosed. So emphasizing how important is TB diagnosis, and to improve the TB diagnosis in this vulnerable population to reduce TB mortality. This major diagnostic gaps comes from the clinical spectrum of TB disease in children that was well described by Carlos Perez-Vélez in this paper where you show this. And you know that unlike adults, which have mostly adult-type pulmonary disease with large cavities and highly bacillary disease, most children have bacillary forms of the disease, which are therefore more difficult to detect from a microbiological standpoint, even if they can be very severe, such as disseminated miliary disease that occur in very young children. So the impact of this type of the disease spectrum in children, the impact on the sensitivity of those tools that we use widely in adults, such as smear microscopy, culture, expert, is that substantial, and it reduces the sensitivity of those tools. When you look at culture, which is considered the gold standard in adults, at most in children, it will confirm 30 to 40% of diagnosis. Of course, microscopy has a very low sensitivity, and even expert of probably all of you, you know how the revolution it is in adults will end up being positive in only 1 out of 4 or 1 out of 3 child with TB at best. So in this context, it leaves 75–80% of children to diagnose with other approaches than microbiology. And to insist a bit more on why we need different approaches and why TDAs are needed, I'll go quickly with you through the results of a recently published paper with the TB Speed group and my colleague Eric Mvalo published recently. And on this table, you can see data from 12 district hospitals and about 35 primary health centers from 6 countries that implemented a decentralized TB diagnostic approach, including expert, ultra, and chest X-ray. And if we go through the results together, you can see that, sorry, I'm having difficulties. Okay, so there were more presumptive TB children showing up at district hospital than in primary health centers. So you had roughly 4% of children coming over 12 months in district hospitals that were presumptive TB, against 2% in primary health centers. Basically, there were more, and those who showed up, the presumptive TB cases, were sicker at district hospital than at primary health center, where you can see, for example, the proportion of children with severe acute malnutrition was almost twice higher in district, 2 times higher in district hospitals versus primary health centers. There were more contact with, more history of contact, more chronic cough, more chronic fever. Interestingly, both at PHC and district hospital, the sample collection methods were implemented almost in 100% of children. So the technicity at primary health centers in those countries was really high, and people were able to implement a sample collection. The TB features were identified in 80% of these children in both district hospitals, but the end diagnostic process was very different. When you look at in details in district hospitals, let's say 18%, so 1 in 5 children ended up being diagnosed as TB, where only 3.5% were diagnosed at primary health centers out of all these children with presumptive TB. And interestingly, the proportion of those microbiology confirmed was higher in primary health centers. So it's very small numbers here, but you can look on the left side, and it's 1/3 of children at primary health centers were diagnosed with microbiologically, when it was only 17% at district hospital. What does it mean? Children are less sick at primary health center. Therefore, there should be more clinical diagnosis. And because usually across the pyramid, I mean, the higher you are in the pyramid, the higher is the proportion of those microbiological confirmed. So it shows really how much clinicians at primary health centers need better diagnostic tools, need to be supported, need to be empowered to make a diagnosis. What are treatment decision algorithms? Treatment decision algorithms are data-driven point scoring systems for diagnosis, and one can be shown on the right part of your screen, that include clinical, microbiological, and radiological features that aim to standardize diagnosis and that aim to facilitate complex decision-making, complex diagnosis for clinicians at low levels of the healthcare pyramid. And you may know that they were conditionally recommended by the WHO in 2022 in the new WHO guideline for childhood TB for diagnosis of pulmonary TB in children below the age of 10. This is an interim and conditional recommendation, and WHO called for an external validation of TDAs as an urgent priority. But after years of, at some point, recommending to have expert-based approach, expert-based algorithms in the 90s, and after not recommending algorithms, WHO made this bold move to say, we need to better support clinicians at lower levels of healthcare to make clinical diagnosis. So this was based, the first two modern era data-driven algorithms were developed by our group and for specifically for HIV-infected children, and followed soon after by Ken Gunasekera and James Seddon's group with similar methods. The WHO based their recommendation on an evaluation that was led also by Ken Gunasekera of the performance of the existing data-driven or expert-based algorithm. And maybe I can explain more. Some of you are familiar with the Stegen-Toledo score or the Keith Edwards score, or even the Brazilian Ministry of Health scores. Those scores were developed based on expert opinion or consensus rather than data-driven, when more recent algorithms were data-driven. Based on this evaluation, and you see the sensitivity and the specificity varies, but is always better than microbiological diagnosis, WHO pushed to have this in the guidelines and to recommend use of those algorithms. To show you in a bit more details what we did in the Penta study, where we developed a specific TDA for children, we did this with colleagues from Burkina Faso, Cambodia, Cameroon, and Vietnam. This was done in the years 2011 to 2014. And based on in a clinical diagnostic cohort, we developed an algorithm that shows here on the left part of the screen that based on logistic regression models that, as you can see, had good area under the curve and a resulting sensitivity and specificity of almost 90% for sensitivity and 61% for specificity. So I'll guide you through this algorithm. So if you have a child with a clinical suspicion, an HIV-infected child with a clinical suspicion of TB, either based on cough for more than 2 weeks, fever for more than 2 weeks, deviation in a growth curve, so failure to thrive, or failure of antibiotics for a pulmonary infection, you can submit the children, you can do the different steps of the algorithm. First thing is history of contact with patient, history of contact with a patient with a TB case. And if yes, the score is 118, and the threshold to start TB treatment is above 100. So a child with this history plus a history of contact can be started on treatment right away. Otherwise, you can go in the next steps of the algorithm with a clinical assessment, and you can see that based on our logistic regression models, fever lasting for more than 2 weeks scored 66, and unremitting cough scored 39, hemoptysis in the previous 4 weeks scored 79. Anytime a child has a score above 100, the child can be initiated on TB treatment. Then there are other more sophisticated diagnostic assessment, chest X-ray, expert MTB RIF, or ultrasonography that score. You can see the details of the score. So the idea is that this is really guiding the clinician and not leaving things so much to clinical expertise or experience, but to a very a standardized scoring approach. How did we develop this? And this is globally how the TDAs are developed. You have a good quality diagnostic cohort where the TB diagnosis and the follow-up is done by clinicians with the best level of TB diagnosis possible in countries, so very high level university teaching hospitals. You do a retrospective classification by an endpoint review committee at the end as TB, not TB based on available data. Then you develop, as I told you, logistic regression models, identifying clinical, lab, radiographic features associated with TB. You get an issuing ROC curve that shows you how discriminative this model is. And here you can see it's a good ROC curve, a good area under the ROC curve, 0.9. And then you select your threshold based on clinical consideration mostly. I told you about underdiagnosis of TB. So as you understand, we will all kind of favor sensitivity over specificity in this selection. And the last part is based on this threshold plus the parameters, you develop a scoring system and you organize things in a stepped approach that is feasible rather than a score, that it presents things in a flat way. You have this kind of stepped approach. There has been recently an effort to develop a new data-driven treatment decision algorithm based on a larger data score. I told you we developed this over 400 children. So this was part of the INSPIRE IPD meta-analysis led by Ken Gunasekara and James Seddon. And they gathered data from almost 5,000 children from a number of countries where you can see the proportion of TB was 38%. And the scoring system that is coming from this publication and this analysis has a sensitivity of 0.96% and a specificity of 0.37. So a rather poor specificity, but that's really the idea here was really again to favor sensitivity to decrease underdiagnosis. And I'm showing this is the scoring part of the algorithm, and to improve the performance of the algorithm, they also develop a first part, sorry, I'm going a bit too fast, a triage or screening part that is based on expert opinion or consensus, and that is trying by identifying children at high risk and having them immediately assessed, or identifying those who are less at high risk and having a round of antibiotic treatment and follow up to see whether symptoms are persisting, to try to increase the pretest probability for the scoring part to improve its performance later on. This algorithm was suggested for use by the WHO in the operational handbook that accompanies the guidelines. And it has two versions, a version that I just showed with a sensitivity of 86% and specificity of 37 that has both a clinical and a chest X-ray component, and another one that has a similar sensitivity but a rather poorer specificity, and that does not include any chest X-ray, and that is really developed to be used at primary health center level if people cannot access the chest X-ray. So this one is really done for primary health centers that can have access to expert either on site or through collecting samples and sending them to a reference lab, and that are able to do a clinical evaluation only. So these are the most recent recommendation for the WHO. Use TDAs and suggestions from the WHO. You can use those TDAs and you should pilot them. You should collect data and contribute to external validation of these approaches. So there are several ways to further improve what we have. First, as mentioned, the external validation of those TDAs, maybe develop specific approaches for specific population, include a screening step to increase the pretest probability that will probably improve the performance of those tests, to do more implementation research on the use of those algorithms, to include the severity assessment in treatment decision algorithm. And you're probably all familiar with the fact that there is a new recommendation to do a 4 months treatment versus a 6 month treatment in less severe disease, and maybe to optimize those algorithms by using or adding novel biomarkers or AI-read chest X-ray. So I'll quickly take you through the different steps. The first thing we actually just finalized the external validation of the first developed modern era TDA, which was developed as to remind you for children living with HIV. So we implemented this test in 277 children from Ivory Coast, Mozambique, Uganda, and Zambia. We were able to complete the scoring in almost 100% of children and to initiate treatment, as you can see, with a median delay of 1 day following inclusion. So showing here the 277 children, almost 78% of them had a positive score, so should be started on treatment, and 22% had a negative score, so should not be treated. During follow-up, in fact, as you can see, not all those who scored positive were treated, and not all those who scored negative were not treated, and clinicians started treatment. The issuing, so we just received the final results of this and the case review by the endpoint review committee. And what it shows that out of those 12, 5 were considered as real TB, so false negative cases, with a resulting negative predictive value of 92%, which was one of our validation criteria. And out of those 184 who started treatment, or those who were considered score positive, 62 were false positive. They were overdiagnosed, which is not such a surprise with a score that has a specificity that is not perfect. So this is really absolutely recent, and I just received this result a few days ago, if not hours. And so we have the final positive predictive value for this score. So sharing here with you really the very preliminary final results. Our score, and we knew this already, is validated per protocol because we had a target negative predictive value above 75%. The treatment initiation was done within 1 day versus 7 days in the mother study. So it shows that we can reduce the time to treatment decision and to diagnosis. We learn by implementing it, and it's not database validation, that a positive score does not always lead to treatment. People sometimes do not believe the score, will make other decisions. And sharing here with you the preliminary results of the sensitivity, which is really good, and the specificity that falls a bit with in the external validation, but globally confirming the performance of this score. I mentioned that maybe different TB approaches should be done in specific population, and notably we are thinking about children with severe acute malnutrition. You know that there's a circular relation between severe acute malnutrition and TB. SAM includes a fall in cell-mediated immunity, and immunodepression due to the severe acute malnutrition, which leads to TB. And TB itself has a catabolic effect and generates severe acute malnutrition. It's a very highly vulnerable group because TB diagnosis is really challenging in this group. Clinical radiological features are poorly specific. Children can be even asymptomatic yet have TB. And there is such a high risk of mortality in children with SAM and TB. In 2 studies that we completed recently, and sharing here the results with you, we enrolled 603 children with severe acute malnutrition, and and this was the only enrollment criteria. And you can see that almost 1 in 5, so 18% had TB, and with a very high rate of micrological confirmation. Most children had pneumonia-like symptoms: acute cough, chest indrawing, tachypnea. So as medical doctors and around the table, a lot of you were trained on the fact that TB is a chronic disease, but in this population, it often presents as an acute disease looking like a pneumonia. And conversely, in another study where we enrolled children with severe pneumonia as the entry point, 25% of them had severe acute malnutrition and 17% had TB. So really this group, there's triangular relation between severe acute malnutrition, pneumonia, severe pneumonia, and TB. That is quite striking. So we thought that for this group, and given the specific clinical feature, we should develop a specific algorithm And this is what we did as part of a study that will be published soon and is in press now. We developed a specific TDA that should be used to assess all children hospitalized with severe acute malnutrition with expert chest X-ray and abdominal ultrasound, and that has a sensitivity of 86% and a specificity of 81% for the diagnosis of TB. So when you have a child hospitalized so this was developed in Uganda and Zambia, a child hospitalized with SAM below the age of 5 should go through a detailed clinical assessment plus chest radiography, plus expert, plus abdominal ultrasound. And once he has all these exams done, you can rule out TB if the score this time is below 10. We use an easier threshold to make calculations.
Excuse me, Olivier, we should start ending the slides because we should start the questions.
The questions. Okay, sorry, I've been too long. I'll take you quickly through a number of, just briefly mentioning that in this study, we tested including a screening step. And so we screen children through very simple questions. Has there been a contact with a TB case? Has there been a cough for more than 3 weeks? Temperature, chest indrawing? And with adding a screening step that has a rather poor performance, the sensitivity is 89%, which is in line with what WHO recommends for screening, but the specificity is 35%. The overall performance of the score is maintained, and it reduces the diagnostic assessment by 1/3, which is not exactly enough. We would like to reduce the number of chest X-rays, expert testing to less children, and there is an ongoing cost effectiveness analysis to assess what's the impact on mortality and on TB diagnosis. And I'll end up by saying quickly that we need more implementation research on TDAs, and this is what we will do as part of the Decide TB project that will be that has started 1 year ago and that is going to enroll children very soon. And sorry, Alfredo, I'm trying to sum up the presentation. So we will test an approach that combines different TDAs in children using the WHO suggested TDA-B without chest X-ray at primary health center level and specific TDAs plus the WHO one at district hospital level. And that will be tested in a stepwise cluster randomized trial soon. And let me go quickly to I would say the two last things is, as you understand, those TDAs for now suffer from a lack of specificity, and we are hoping by including later on possible biomarkers to improve the performance of those algorithms. One biomarker that could be used is, for example, the CFID host response cartridge that was tested recently by Laura Aldrich in children from the RAPID TB trial that has a good performance to distinguish confirmed TB versus unlikely TB, is not doing so well when you consider those with unconfirmed TB, and you can see that the ROC curve is rather flatter, but maybe other biomarkers could, or this one could be improved to be included in those diagnostic algorithms. Also, an area where we could probably improve things is the use of computer-aided diagnosis for childhood TB, detection on chest X-ray. We know from work from Megan Palmer from Stellenbosch University that we can train the existing algorithms in adults to detect TB in children. And this is probably something that will be available soon in improved TDA treatment decision algorithms. And I'll go quickly just and conclude on the fact that those TDAs are also opportunity to integrate an additional step that is not existing so far, and that is recommended by WHO on the evaluation of the disease severity to be able to prescribe shorter treatment. And this could be done really quite easily because WHO has now recommendation based on expert and chest X-ray that could be linked to the WHO TDA-A and also has a recommendation to assess for severity without the chest X-ray that could be done also at primary health center. So everything moving toward in the right direction. And with that, I'll conclude saying TDAs are now recommended for TB diagnosis by the WHO. They are progressively pilot tested in a number of countries by different groups, including the WHO TDR, Epicentre, MSF, our group. The first external validation study shows high feasibility, good diagnostic performance, and hence confirms transportability to other sites. It's been developed in those countries. It could be transported to others, and it's rather stable. We do think, but we need more implementation research that it will play a key role at district hospital and primary health center level. More external validation is needed. And definitely it could be improved or optimized through incorporating new biomarkers to improve its specificity, improve a screening step, or restrict invasive exams to children with high pretest probability in a clinician-like Bayesian approach. And maybe, and I think it's the future, allow for individualized treatment approaches. You don't look of the chest X-ray of a 2-year-old child as you look at the chest X-ray of an 8-year-old child. And this individualized approaches with different TDAs for different groups could be supported through clinical decision support systems that are rather easily available on your cell phone or smartphone.
The aim of my talk was to give you an update. I'm not going to go through many research studies that we are conducting in our networks, but I just wanted to make an update with a more clinical perspectives of some new approaches that have recently been developed and that can be useful for our clinical practice, and also with some insights in the future. So this is the index of my presentation. I will focus. I will do first a little bit focus in pediatric TB, although Olivier has already done it in his very nice presentation before, and then I will go through some new diagnosis, treatment, and surveillance tools. So first, I will focus a little bit on pediatric TB. Olivier has already said. And this figure comes from the WHO last global TB report. And as he said, around 10% of tuberculosis cases in the world take place in children. This is estimated that 1,500,000 adolescents and children younger than 15 years and 700,000 children under 2 have got TB. However, it is estimated that around 1/2 of these children do not reach a diagnosis, and as a consequence, they don't receive treatment for TB. This slide is the typical epidemiological slide from the WHO from the last global TB report. And TB is very different throughout the different regions from the WHO. In the place where I live in Madrid, in Spain, we have the lowest incidence of tuberculosis in the world. However, in our countries, in European or in high income regions, TB is very far away from being controlled. And there are particular groups very vulnerable to tuberculosis, even in our region. So the spectrum of TB is different throughout these different scenarios. These are 2 examples of 2 adolescents that I have recently gone through. One is from Angola. These are around 13 to 14 years. This was a child with tuberculosis, with a very severe pneumonia. And this was a child from Madrid. He was 13 or 14 years. And this was his chest X-ray. So we have very different spectrum of the disease in different countries, but all of them have got TB. And we have many challenges for the diagnosis and treatment in both settings. So one important thing that Olivier has said is that the WHO has recently released very good guidelines that goes with different aspects of tuberculosis management, from surveillance to treatment, diagnosis. And there are 2 new guidelines specific for children, the consolidated guidelines and the operational handbook guidelines, that are very recommended, very practical, and they give a lot of information. This is something important. And in these guidelines, one of the novel things and very important for our clinical management, and based on previous trials that I will later go through, there's a new paradigm of what is tuberculosis and how do we have to treat it. So now we can distinguish between two types of TB according to disease severity, and children with non-severe TB can benefit of short course treatments. And this is something that is very useful, especially in countries like mine. This is a very nice study that we conducted within the Spanish Pediatric TB network. It was conducted by Alicia Hernández, a colleague from my hospital, and we reviewed the cases for the last years in Spain to see how many had non-severe TB. And we found that more than 60% of the children in our country have got non-severe tuberculosis. This is very important considering that now they can benefit of short course treatments. However, as you can see in the slides, children under 1 and adolescents have got higher rates of disease severity. And in these cases, non-severe TB only takes place in around 35% of the cases. So these are particularly vulnerable groups, young infants and adolescents. And in Europe, there are two important vulnerable populations in children. First, immigrants. In this picture from the ECDC, you can see that in high-income countries like North America, Europe, Australia, around more than 50% of the cases of tuberculosis take place in immigrants. In the last decades in Europe, we have experienced two very severe refugee crises. One of them was in 2015, I'm sure you all remember, the Syrian crisis. A lot of children came to Europe, many of them non-accompanied minors. And also in 2022, we had recently the Ukrainian crisis with a lot of children also traveling to Europe. And in these situations of poverty and overcrowding, tuberculosis is a very high risk. But also, despite this crisis, we have also a very big problem with immigrants coming through our borders. And these are the main routes of entry in Europe. And here you can see in the last decade, the number of immigrants coming through these routes. In 2015, during the Syrian crisis, there was a big number of children, but also in recent years, we recently had a big increase in these numbers. And I told you there were two important vulnerable groups. One was immigrant children, and the other group is immunocompromised children. So now in high-income countries, we experience a higher number of children vulnerable because they have children with hematological stem cell transplantation or children receiving solid organ transplantation. They have longer surveillance, and also children who receive chronic medication because of chronic medical conditions or biological agents. This is an increasing group at risk of tuberculosis. And this was a very nice study that we published recently. It was published by Paula Rodriguez Molino from La Paz Hospital, but this is a study conducted by the European Pediatric TB Network, a case control study where we looked to all the immunocompromised children in our database in Europe. And we found out that something that we already knew, but we could say the numbers, that children with immune disorders have very low yield of immunological tests and other diagnostic tests compared to non-immunocompromised children. So I will go now, I think I'm fine of time, to review very slightly. I will not have time to go deeper in all these new tools available, but I just want to show the things that are going to come or that are already around us and that we have to start thinking about to use it and to implement it in our clinical practice. First, we have to optimize the diagnosis. And then here, Olivier has recently explained the origins of the WHO algorithms, but clinically is very important. But however, chest X-ray continues to be the cornerstone of diagnosis, and it has gained importance in last years. Some of the WHO algorithms, as he said, are based on chest X-ray, but also the Shine tribe that defines shorter treatments. They established the category of non-severe TB, mostly based on chest X-ray findings. And then recently we had this very nice tuberculosis atlas that was released by Megan Palmer and her group that have very nice pictures, and I strongly recommend you to go through it. But however, chest X-ray has low sensitivity, low inter-reader agreement, and it needs human readers. So here comes POCUS, the point of care ultrasound. And this also can be very useful for the diagnosis of tuberculosis in children, because this is the perfect point of care test that we need for children. We can do it in the bedside, it's non-invasive, it's child-friendly, we can have results immediately, it's cheap, and it's even portable. We can use it in our smartphones, in our tablets. And in tuberculosis, we can scan the lungs, the mediastinum, and the abdomen. And we can have a lot of findings that can help us for our diagnosis. I am not an expert at all in this, but in the lungs, there are the A lines, there are the B lines, the A lines that are normal, B lines that are pathological, and consolidation. This is the ABC of lung ultrasound. And with lung ultrasound, we can identify pleural nodules, consolidation, cavitation, miliary TB, pleural effusion, and pericardial effusion that are findings very suggestive of TB. And then we have mediastinal ultrasound. Through the mediastinal ultrasound, that it requires a little bit more experience because it's like more similar to echocardiography. We can reach very different difficult to access regions of the mediastinum. And there are different projections. I got these pictures from a very nice study from Isabel Muyangahu and her group is global that we are conducting between Mozambique and Spain. And we are trying to evaluate the performance of mediastinal ultrasound, because with mediastinal ultrasound, we can reach places that we cannot access with lung ultrasound, with thoracic ultrasound. And this can be very useful for the follow-up of children with mediastinal lymphadenitis. This is an old study because the mediastinal ultrasound has an old history, and many people decades ago thought that they had to be developed properly. Here we can see in specific patients how we can follow lymph nodes, how they decrease. Here we have the same lymph nodes in the follow-up of the children, how we can follow and see how they decrease from one to the other. And this can avoid the exposure of children to radiologic radiations. And third, we have abdominal ultrasound that can be very useful to identify focal liver lesions, abdominal lymph nodes, or focal splenic lesions that are also very useful for disseminated or abdominal TB. There are not many studies because this is difficult, because we do not have a proper, in children, gold standard test. So it's not very easy to perform because the chest X-ray doesn't have good sensitivity and it's difficult to compare, but it was a very nice study conducted in Guinea-Bissau, and in children with confirmed TB, they found a sensitivity of 85% and a specificity of 66%. That maybe do not seem to be very good numbers, but the sensitivity and specificity of normal chest X-ray is not higher than this. There are not many studies of ultrasound in tuberculosis in children, but there are a lot of studies of POCUS in children with acute pneumonia. This is a systematic review and meta-analysis that reviewed thousands of children, and they found a pooled sensitivity of 0.94 and 0.93 specificity, and an area under the curve of 0.98. compared to the clinical or radiological diagnosis. So at the end, tuberculosis is a pneumonia, and we can get the experience of the diagnosis of childhood pneumonia and to implement it and to translate it to the diagnosis of tuberculosis. So Olivier has already talked a bit about artificial intelligence, and in fact, in the consolidated guidelines for the screening of tuberculosis in children by the WHO in 2022, it is a point that recommends for TB screening the assessment of chest X-rays with computer-aided diagnosis in place of human readers in people older than 15 years. So this is not in the future, this is in the past. WHO recommends using artificial intelligence for the reading of chest X-rays. So if we don't use it, we are old-fashioned. And we already in our hospitals, maybe it's not implemented, but recently they sent me this picture from one hospital in Madrid. This was an adult, and this is not tuberculosis, but they have already the tool implemented in the clinical practice that gives you a proportion of probability that this is, for instance, an interstitial pneumonia. So we already are starting to use this to support our management of children and adults. In this website that is conducted by Stop TB and Find, they make a review of the artificial intelligence solutions that we have already available for the diagnosis of tuberculosis. You can see here, I have put the numbers. Many of them are available for children young, older than 15, but some of them, and these are already certified and are ready in the market, some of them are for children, and even for children from 3, 4, or until 2 years. But we don't have tools for children under 2, although this has been in development. There are some solutions pending certification, like this one from that is Chest AI, and there are other solutions for adults under development. So there are a lot of tools that will be available for us in the very near future. And this is another study similar to the one that reported Olivier. This compares two computer-aided diagnosis tools, one refined compared to the other, and compared with using as a reference standard culture confirmation. The more refined tool had an area under the curve of 0.78, which is not bad at all, considering that this is only the diagnosis based on chest X-ray. And to this, we can add clinical, epidemiological, or microbiological confirmation that can increase with different algorithms or combination of factors. We can increase the area under the curve. So, and then the stool test. The stool test is implemented in some parts of the world, but not in Europe. We don't do it as much as it is recommended. The 2021 guidelines include for the diagnosis of TB that we should undergo expert ultra in sputum, in nasopharyngeal aspirates, in gastric aspirates, but also in stool, rather than smear microscopy, culture, or and also drug susceptibility testing. So we should do this. A stool, in fact, is not an intestinal sample. A stool has to be regarded as a respiratory specimen because children swallow a sputum containing bacilli from the lungs, and it has to be a respiratory specimen too. Well, this is conducted by a gene expert by the same cartridge. You know that gene expert for the diagnosis of TB was a revolution in the last decade, and that since it was released in 2011 for respiratory samples, now we are the other point, 10 years later, and it has been recommended by the WHO. And now we have improved gene expert cartridge compared to the beginning, that is expert ultra, that is the one that is recommended by the WHO. I will not go to all there are a lot of systematic reviews and about the performance of stools, molecular tests in schools, but I just go to this summary in the WHO guidelines. And if we compare, this is the previous version of Gene Expert, and this is the Ultra, the last version. We compare the performance, the sensitivity, and the specificity compared to sputum, to gas, to other respiratory samples. We can see that the performance is very similar or even better than others like nasopharyngeal aspirate. So definitely we should try to implement it in our clinical setting. However, there are very few studies in Europe, and we don't know if this performance that has been based on the experience in high burden countries is the same in our countries. It is a little bit messy to do the stool test, and our microbiologists have to take into consideration that the sample needs to follow some processing. The WHO recommends one processing that is called the SOS. It was developed by KNCV, and there are videos in their website where they make a lot of recommendations of how to do this. And then optimizing treatment. So we have to offer our patients the best thing that we have. And 2 years ago, it was published in New England, this clinical trial. I'm sure some of the authors are here in the webinar. That was a very, very good news for the ones who treat children with TB. And I really always have to congratulate them for this trial. And they demonstrated the non-inferiority of a short course treatment in children with non-severe TB compared to the classical 6-month therapy. This non-inferiority was obtained in terms of efficacy and also in terms of side events, adverse events of medications. So this is one thing that we have to do with our children, to give them short treatments. Also, we have to improve the way we monitor treatment. So we know that we have to give many drugs, combined adult drugs that are not performed for children, that do not take into consideration their metabolism, their body size, etc. Most of them, despite this, and despite big efforts at the end, they tolerate well and have clinical outcomes, but it's really very difficult to give them this adult medication. And in addition, these medications have got side effects, and we have to teach very well children, our parents, to identify their symptoms, and we have to follow them very closely to see if they have adverse events. So these are the typical drug adverse events from the TB drugs that I'm sure you all know. Rifampin, isoniazid, pyrazinamide, all of them produce liver toxicity, and but also isoniazid peripheral neuropathy. That is why we have to give pyridoxine. Pyrazinamide produces arthralgia, myalgia, also skin rashes, and ethambutol produces optic neuritis. So we have to be very careful and to monitor before this happens. Liver toxicity is one of the ones that makes her more scary. However, we only have to monitor liver enzymes in particular cases, because normally when we start TB treatment, around 40% of the children will develop very low but transitory elevation of transaminases. So because of this, we should not test everyone, because this is transitory and we will be confused and maybe stop drugs that do not need to be stopped. There are some conditions that we have to take in consideration, and in these cases, we have to follow up liver enzymes that are baseline hepatic conditions, like congenital or neonatal lesions, acquired lesions of the liver, inborn errors of metabolism, genetic disorders, acute hepatitis, or hepatosteatosis, other children with immunocompromise, children with immunosuppressive drugs. Children that receive drugs that are metabolized by the liver, and also particular sites of disease such as disseminated abdominal of TB meningitis. In these cases, we have to follow up liver transaminases closely and stop them if a child is symptomatic and there's an increase 2 to 3-fold, or if the child is asymptomatic but the increase is more than 5-fold. In the PTBnet, we developed a very nice info sheets in all the languages that you can ask for us. They were developed by Florian Gotzinger, and these are pretended to be given to the children or their parents, and they show the main adverse events of medication and what do they have to do, call the doctor or go to the clinic.
Begoña, just to let you know, we had 20 minutes in your talk. Just to let you know, you had 20 minutes in your talk.
Okay, I will finish in 2 minutes. So, and another thing is therapeutic drug monitoring. That is something that we have to take account when we have a child with treatment failure, severe disease. We are worried about drug interactions, impaired absorption, or clearance. This is not implemented everywhere, but this is something we have to think about. And at last, child-friendly medications are available in high-burden countries and delivered by the global drug institutions, but we don't have them in Europe. However, there was a big effort by some clinicians led by Dr. Noguera. He's an expert in TB from Barcelona, And we made an agreement with MacLeod, that is the company that develops these drugs, and we have available now in Spain and probably in other parts of Europe through foreign medication. And this is something that we have to think about to improve the treatment of our children. And then just to end, although I will not have to go through it, we also have to think about novel tools for doing surveillance. The classic epidemiology looks for TB cases in the concentric circles strategy through interviews or with the parents and the families. However, genomic epidemiology can give us a lot more information, because sometimes we can, through genomic analysis, we can find out that the transmission takes place in places different to the ones that we think through the interviews or contact traces, because we can find specifically the strains and clusters. This was a case that we had in our hospital some years ago that was admitted. Well, first he had an acute otitis media. He was admitted. We found that he had this abnormal radiology, and well, I will go just to. He was initially diagnosed of cefotaxime, but we performed a PPD and quantiferon, it was positive. So this child was initiated on TB drugs. And his teacher during the last month had a very severe and persistent picture of cough, malaise fever, and had been wrongly diagnosed of pneumonia, received several cycles of antibiotics. But when she knew that this child was admitted, he was also admitted to the hospital. He was diagnosed of a tuberculosis, and it was confirmed microbiologically. Our public health institution screened a big school of around 500 children, because this teacher was the English teacher, but also she took care of all a big group of children under 6 years of age. And I don't have time to go in detail to all of this, but at the end, among all the around 400 children screened, we found 64 children were PPD positive, and at the end, 36 children have TB and 28 have TB infection. The important thing I wanted to tell you is that thanks to genomic analysis conducted in our hospital, we could identify the cluster of the teacher here in this year, in 2015, the teacher and all the TB cases that we have with confirmed TB in this outbreak, and we could link it to a previous outbreak that took place in the same school some years ago. This teacher, there was 2 cases of TB, and this teacher, because it was close to summer, she didn't go to do the epidemiological and TST, so she was lost in this scenario, but we could link these new cases to the ones before, and this helps us to identify that this is a reactivation of TB and not a new infection, and this can be very useful. So just to end, the take-home messages: first, that times change quickly, and it's critical to know all the new technologies that are available, and we have to also be fast to implement it in real practice. These new approaches include POCUS, stool tests, short regimens, dispersal of drugs, but also artificial intelligence, and some new tools that will be close to us soon. Our approach has to be oriented to our patient, our family, and also we have to do many research efforts to offer more insights to combat our pandemic in a region like mine, but to implement all these also benefits for those places where TB has the greatest mortality and incidence.
I think, Oliver, thanks very much, and you answered many of my questions. So do you, like, it's maybe a bit provocative, but do you, I think you're probably part of both TDAs, your groups, you know, that you've driven this, and also WHO, you know, I think you are, you know, contributing or working with the same people. Do you think which one is better? And which one has got maybe place for different settings, and you know, what are your thoughts about it?
Yeah, thanks for the question. I was indeed part of the Inspire group with James and others. I think for now, what is better is what you can do. So you want to have TDA-B from WHO at a primary health center level, and you want it applied, and you want people to be able to make diagnoses, because as you saw from my presentation, they will not. Most of them will rule out TB on a negative expert test, and so you need to improve this. But at district hospital level, I mean, it's a shame that people would not have access to X-ray. So we need to push for that. But if it's not available, it's TDA, TDA-B that should be applied. So I think TDAs are not interesting only as a single tool, but as something that will evolve. It's quite amazing to see that Begoña presented all those tests and that we are trying, that she wants to use in Europe, or possibly is not always using or wants to. And we try to have them available and usable at low levels of healthcare by people who are far less experienced clinician than Begoña, or who have, kind of less clinical skills. So I think the TDAs are the way forward. And there is still a lot of work to do, but I mean, we are pushing for point of care ultrasound at district hospital level in high TB burden settings, and we should have that. Possibly it will be better and easier than chest X-ray. So we need to improve those algorithms.
But we also need to recognize that it's maybe not available for many years in many settings, and the tools that are available now, like but mobiles are available everywhere. Like lots of people are using mobiles, so it's kind of like user-friendly mobile app, because otherwise I won't be able to add all the scores in WHO algorithm. It's quite complicated, and if you see like you have 5 or 10 minutes per patient, it's just not really practical. So, but that we are looking forward to your digital tools that are user-friendly. Thank you.
Thank you, Anna. There is some questions also from Noela Pereira. I don't know if you want to speak up, or I can read it otherwise.
Yeah, I just wanted to ask if, Begoña, if you all had any cases of drug-induced liver injury in your children with who were given drug-sensitive TB regimens amongst those children that you saw?
I cannot tell you exactly a number. I'm sorry, but I don't have those data. But it's not very common, but we have sometimes these cases, and it's quite difficult to identify exactly which is the drug that produces the liver toxicity. In general, it's not a common situation in children. However, it can happen, but I'm sorry that I cannot give you exactly the exact proportion.
No worries, thank you very
much. However, it's not high.
Because we do see some of those in India as well, where I was just wondering, and it's sometimes quite tricky to figure out which is the culprit, which drug actually.
It's very difficult, and you have to start one by one, and it's very difficult sometimes to decide. And yes.
Also, there was some comments from Balingwant. You wanna take the word, Balingwant? Maybe he had to leave.
My questions has been answered by Dr. Olivier. Yeah.
Okay. There's a question also from Marisa Navarro. You want to speak up, Marisa? The question is, what do you think about the TB-LAM? Do you have any comment to do about TB-LAM in urine?
Begoña, are you using it?
In Europe, we don't use TB-LAM. We don't have in our clinical tools that we have, but it is used in other parts of the world, especially it's specifically useful for children with HIV. But I don't know, maybe Olivier, you are more used to it.
Yeah, as you know, it has shown a major clinical impact in adults with HIV. I mean, despite being a poorly sensitive test, it's highly specific, and it leads to good treatment decisions in adults that are not detected through others. So it does change mortality, impacts it. It reduces mortality. So it has been recommended in children. It has this similar performance in children with HIV, and now we have more data on children with severe acute malnutrition. It's still a bit controversial, but it's probably a test that could be used also in this. population, and we are trying, just as I was saying, we are including biomarkers or future biomarkers. We will test this soon and see how it impacts our algorithms. The idea is when you present Begoña and you see when people are left with decision making on the basis of all these approaches, they are a bit lost, as Anna was saying, and they are used to do diagnosis on 3 variables. Is the child breathing quickly? Yes. Does he have chest syndrome? Yes, it's a pneumonia. No stethoscopes, no chest X-ray, pneumonia, 3 days Amox. This is IMCI at primary health center, very basic. So we are coming in with chest X-rays, expert, lab testing, 7, 9, 10 variables, including tachypnea. So I agree that we need to help them make the right decisions. Definitely LAM is and it's largely recommended in Mozambique and Zambia where we work. It's largely recommended, and we need more data to incorporate it in the algorithms. And I hope children in Europe get the LAM test too. It's crazy sometimes. Like we don't have rifampicin, for my colleague from Paris hospitals. They said, but we don't have the FDCs for children. So now the good news is that it seems to be available. But
may I have the benefit of here in the panel to ask you something, Olivier?
Sorry, I'll have to cut you because we're out of time. We are 10 minutes past the hour. We actually have an announcement. So over to you, Constanza. Please give us an announcement. We have Penta.
Yeah, thank you, Tizu, but I don't need so many times. So if you wanna give the floor the chance to ask a very last quick question, please. Okay. You are free to do that.
Okay. One last question. So let's go ahead. Yeah.
Can I ask Begoña then? Begoña, if it's quick, how did you get this dispersible tablets in Spain for kids?
Well, Tom had very long conversations with MacLeod's and with our drug agency, the Spanish drug agency, and they had many conversations, and at the end, through medical medications, we can have it. So despite it is not approved by the EMA, we can ask as a foreign medication. So we receive like stocks of medications centralized in Madrid. We have received like 2 stocks, and when we are run out of it, because people from Spain can all of us ask to get it, then we have another stock. I don't know, maybe Tom is listening to us if he wants to add something, but this has been a process of years, and at the end he could get it. That being the first country, probably this is the door that can open the availability of the drugs in the future, because if we ask for it, we will have it, we will have more. So if we increase the demand, we will have the opportunity of having more.
Yeah. Do you know if the MacLeods have any plans to register with the EMA?
Sorry, excuse me. There was a telephone ringing. Sorry, Anna, can you repeat?
Do you know if MacLeod have any plan to register the dispersible tablets with EMA? Because this is the medications I think we used in Shine, and we had the chat with them for a very long time. I know it's available and registered in one of Scandinavian countries, but is it for us then to buy from them directly? So it's quite complicated, yeah.
I think they are in the process of regulating it, but I don't exactly know at what point, and this is something that goes very slow.
Okay, I think we may need to write them all together. Thank you.
If I can also leverage the occasion to ask both of you about the GenExpert, when there's some people working in low middle income countries struggling with the result, which is very low and sometimes seems to associate with false positive resistance to rifampin. Do you have any experience with that?
You said very low, the result of GenExpert very low, and about the resistance, I didn't understand you, Alfredo.
No, that sometimes when the result is very low, and sometimes looks like this is linked to false positive resistance to rifampin result. Any experience with that?
I didn't hear of that association. I know that if we
had a child recently with very low positive, and they reported indeterminate rifampicin resistance, and explained that it's really difficult. So they said indeterminate, which makes it really hard to kind of be confidently managing them as drug sensitive TB, especially if at the end of the TB you do chest X-ray and there's some residual changes. You really don't know.
No, definitely. The trace results, not very low, but trace results is usually based on IS 6110 rather than detecting the RPOB, which is used in the old expert. So when you detect the RPOB, you are usually able to detect whether it's mutated and hence induces resistance to rifampin. So the question is more on how should we consider trace results always as true positives. We do in HIV-infected children, in children with severe malnutrition, in children who are not well. If you have a rather well chronically coughing child of age 8, maybe you will wait a bit and try to get more samples. But it's always a matter of putting this in a clinical environment, hence being Bayesian, and weighing pros and cons of this and that. But
but there is also when it's low. I will send you the reference.